What we offer as Celeri Health is, I call it scratching my own itch. I'm in a busy private practice. I don't have time to make sure all my spreadsheets are up to date, to make sure that I'm following up with all my patients. I want to automate the busy work. I only want to be notified, or my research coordinator notified, if we're actually missing data points on our patients. So the real world outcomes platform was purpose built by Jason and I. We sat in an airport, we looked at the amount of work we were doing to capture and structure data in our clinic, and it was staggering. It was not reproducible. It was not a method that could necessarily be translated to everybody else's clinic. And we decided that we needed an interoperable patient reported outcomes platform that also serves as a device and procedure registry that works in any practice and can facilitate clinical research, investigator initiated research, collaboration, all of those wonderful things, but it can also help you treat the patient right in front of you and learn from the performance of devices inside your clinic. The solution is simple. We provide gold standard common measurement languages capturing real world data that can benefit you, your patients, and society. We use standardized and structured data capture, validated measures using NIH Promise and other validated gold standard measures. We automate the busy work, and we'll show you how every time I implant a patient, I set them to get assessments at a regular cadence for the next 2 years. We have a FDA compliant workflow on our EDC or electronic data capture side, and we have instant data as soon as that patient's completed the assessment available for use in your clinic. We also understand that in order for this to work, for us to radically change the way that we add new understanding and new guidance to each encounter, has to also be supported. And there are reimbursable CPT codes that, when medically necessary, can actually facilitate this. And again, as we mentioned, the last 10 years of expert consensus documents from both the NIH and the Interagency Task Force, et cetera, all reinforce the necessity of moving towards a multidimensional assessment model, and in fact inform us that this should not just be supported, it should be encouraged and incentivized. We want you to be able to focus on the results for each encounter, to use this as a tool to drive research, to understand and ask questions about the performance of devices in your practice, and to escape the noise that is marketing, because marketing doesn't help your patients. So you need to know in truth what's happening in your clinic, because RCTs are wonderful to inform decisions to introduce new therapies to your practice. But to maintain them in your practice, you need clinical experience. Otherwise, you have no compass.
Yeah, I think that that's really wise because as we described throughout the call, people have different skill sets. People's hands are different, and something that may be really great in Michael's hands may not perform well in my hands. And for me to continue to do that and blindly continue to do that and not assess patients in a validated way, it's a detriment to the community that you're serving. And so it's important to look inward introspectively at how you're doing, and then to look how your patients are doing, and then adjust. We talk about these inflection points, and I use the Promise 29 every time someone comes into my practice, because I want to detect if there's a meaningful change, whether it's a supported meaningful change or whether we did something that was not supported. And if you don't ask the question, you can't get the answer.
And so here's a detail, and we'll show you some more details of what the typical in-clinic report looks like. We treat the Promise 29 just as Jason mentioned, and it's a little tongue-in-cheek because there's a rough history to this phrase, but we treat the Promise 29 as a fifth vital sign. And I think one of the misses that ultimately occurred in the 90s with JCO, where pain scores were the fifth vital sign, is that they actually missed all of these other factors. And with a much more robust strategy, it really can help us understand that pain scores should actually be de-emphasized. When we look at, for example, the pain impact score, which is something that we plot and calculate for every patient. Here you see a pain impact score. It's much more telling. This patient has very low pain, that's true, but their pain interference and their physical function is relatively poor. They have moderate impact pain, even though right now the pain intensity, or over the past week, that's the look back of the Traumas 29, the pain intensity has not been severe, but the impact on their life, the interference with activities of daily living, and their ability to perform physical feats that most of us would take for granted, that's really how we can help our patients and restore their function. And to do that in a way that allows you for continuous process improvement in your clinic, just as Jason mentioned, harness this with every visit, use it to make decisions on your care. This is a much more sound strategy, especially because I don't know, everybody practices in different areas. Here, people are very polite. So I ask people how they're doing. They tell me they're doing great. But then I look at their Promise 29 and I said, that's not really true. What's going on? And I've had many patients who I think if I had just allowed them to be polite, I would have missed on somebody who's severely depressed or severely anxious or has a terrible sleep disturbance or fatigue. And so this saves me time in my practice. And for my advanced practice providers, they look at this and they've been instructed to look at this as a compass for every visit because it really helps you understand, hey, what do I talk about today? And I think as we've moved to a telemedicine strategy across many of our clinics and many of our encounters, it's even more important because without the physical examination component, what's your visit really about? And I think that this is a great opportunity for us to focus on the psychological and social aspects of pain care, whereas traditionally we focus mostly on the biological features.
Yeah, and I think to operationalize providing a validated instrument is critical. And Michael talked about filters, and there's filters that patients provide because they want to be polite, and there's filters that others talk about. For example, if we have a patient that comes in, and most practices that I'm aware of, they usually rely on their reps to give them documentation surrounding how well their patients are doing, and oftentimes there may be a discrepancy when I ask how my patient's doing with stimulation therapy, and they say, oh, we reprogrammed and the leg is fine, and then when we talk and we drill in, there may be a challenge with the back. And so I think that getting information directly from the source is critical. And I think that's going to be the theme when we think about this upcoming conference season. If we are going to have conferences this season, it's really going to be about patient-driven outcomes from patients, and then looking at performance of therapies, whether it's physical therapy or interventional care, radio frequency. I know that that's a hot topic now for those of you that are paying attention, but there's a lot of opportunity to acquire big, robust data sets meaningfully by getting the data directly from the patient, and then we can actually move a space. And I think that's what's so important about this.
So here I want to show some details on what the typical reports would look like in your clinic. And for me, this is very important because on the left side, and this is actually real data from a patient of mine, masquerading now as this non-existent patient who's, gosh, 111 years old, which is fantastic. This guy's doing great. What's important to me is that, one, we have a rich baseline. From the moment the patient enters our practice, we start to understand how they are doing. And as they progress through episodes of care, we can continue to follow them and track them. Now, in this patient, you'll see that they had a spinal cord stimulator trial right here at this inflection point. Dramatic improvement in pain intensity, really, during that trial phase. You see in this plot bar that the patient's entered the implant stage and ultimately has actually done very well with a longitudinally decreased pain. And additionally, and at the bottom, you'll see device details for any of our patients who have had an implanted device attached to them. You'll see this continuously updated device details that gives you long-term improvement. On the right side of the screen, you look at a longitudinal ZCQ, and this is a patient who has an interspinous spacer that was implanted on March 12th. And thereafter, you see that back leg pain has dramatically improved. Excuse me, and this patient had very little back pain. Leg pain has dramatically improved. We see a 70+% improvement in leg pain. We see improvements in the ZCQ symptom severity scale and physical function. These data sets will continue to populate for this patient. In my typical patients, they'll receive a text message or an email once a month to assess them post-operatively. In your practice, you'll then have an option to look at very briefly and very quickly the percentage and proportion of different devices in your practice, types of devices, models of devices. This can be immensely helpful when thinking about opportunities to reprogram patients if new therapies become available on certain systems. It helps you understand if you're performing or considering performing a research study, what that population with a uh, similar device parameters looks like. And it also will give you general data on things like trial to implant ratio, etc.
Yeah, I think that's critical because when we have when we're trying to move the bar when it comes to having discussions with insurance carriers in my community, a lot, we are a step ahead because we're actually capturing this data. So I can tell them very quickly when someone is referred to us how well they're doing, and we can talk very quickly about our successes from conversion from trial to implant, and then we can potentially compare one treatment strategy from another to talk about cost effectiveness. And so having this data is important, and looking underneath the sheets to try to decide how best to engage with insurance carriers, and then how better to engage with your community.
We also have the opportunity to integrate with any EHR. Now, I would share with you, this is Jason's practice. My practice, this is not integrated. And that doesn't bother me at all. We also integrate with Dropbox or Google Drive or any other variety of HIPAA compliant cloud storage solutions. But you can see here how the Promise 29 was completed by the patient. It's immediately available in Jason's practice. And he can pull up those details, or his nurse practitioner can pull up those details and use that to actually guide care for that patient. Those assessments can be pushed remotely by SMS or email, or they can be obtained in your clinic on a tablet with a iOS app or a lockdown browser. What's most sexy about this, though, is not just that you can use this for every patient encounter, it's that you can finally have access robustly to data in your practice. And these visualizations can be customized to your practice, and we can take you through in a more robust one-on-one demo what the power of having data surrounding the collective improvement of your patients is, noting who are the responders to therapies, who are non-responders. How can you identify those patients who are doing really much worse after some episode of care? And of course, the names and numbers types of things. What kind of devices are you deploying in your practice, and at what time?